talk about mechanical ventilation. The first thing that we'll discuss is that with ventilation there's non-invasive and invasive ventilation. We'll start off with invasive ventilation, which is likely what you've seen more of in movies or TV, generally speaking. So we provide invasive mechanical ventilation through an endotracheal tube. The other option is providing it through a tracheostomy tube. But we will start with an endotracheal tube for the moment. So endotracheal tubes they come in different sizes. They could be small, like this one, for example, is a 6.0 tube, whereas you might have a size 7 tube, or even you might find yourself with an 8.5 tube. So in adults, normally speaking, women will have a 7.5 to 8, and men will have an 8 to an 8.5 tube. And whereas the 6 will be either for very small adults or even just older children. And in pediatrics and neonatal, you have even much smaller tubes, actually. So one of the things when it comes to nursing care, when you do your assessment, is actually looking at the size of the tube, but also looking at the placement of the tube. So essentially, when the tube is inserted, it will be pushed into a certain amount of centimeters that are indicated here on the tube. And this is an assessment that you want to be doing to ensure that when you did your initial assessment, when you came in at the beginning of your shift, if you were at 22 centimeters, as you progress through the day, you want to ensure that it stays at 22 centimeters. So these endotracheal tubes are usually taped to our patient's face through different, either sometimes it's just some tape, other times it's ribbon, and we have also fancier methods of ensuring that the tube does not move from the patient's lungs, essentially. At the tip of this tube, there is a balloon here. So the way that once this tube is inserted into our patient's airway, we will inflate this balloon, and the balloon will stay inflated as they are receiving mechanical ventilation. There is a way for us to assess if these balloons are overly inflated or underinflated. If they're underinflated, you will actually hear gurgling come out, because what will happen is that as this is inserted in the airway, this tube passes through the vocal cords that are around here. And if there is air, if the balloon is slightly deflated and there's air that's passing through and into the vocal cords, it will make a sound. If it's overly deflated, the risk for that is actually causing necrosis on in the airway, and that can cause obviously additional issues. So we wouldn't want any necrosis, so we do not want this balloon to be overinflated. The way that we assess the balloon is actually with experience, by just feeling the tip of the balloon that's outside the mouth over here. If we're able to squish it and it comes back to its original shape, usually that's properly inflated. If we press on it and it's very difficult to press down, it's usually overinflated. And if it's completely flat, that's underinflated, obviously. That being said, there is also a way to measure and to connect a manometer directly to this cuff that we could connect right here to actually measure the proper pressure in this cuff. And this is usually done by respiratory therapists when they'd like to ensure that the balloon is properly inflated. Now, the purpose of this balloon is, some may think, to secure the tube and to ensure that it does not come out of the airway, but that's actually not the case. What ends up happening is that the ventilator will come and connect right here. And the ventilator will push air, so positive pressure, through this tube and will come out here down into the lungs to ventilate the lungs. What this balloon ensures is that the air does not come back out around this balloon. Otherwise, our patients will not be getting the treatment that they require with this mechanical ventilation. It does also allow that from the mouth, that is around like here, that any secretions that we have in the mouth that may drop down above the cuff here will not just fall into the patient's lung and potentially cause a pneumonia. They may actually end up sitting just on top of the cuff, and we with the suction catheter can actually go and suction out those secretions as needed. Now, As I said, there could be different tubes, and one of the an additional tube that we may see in practice is that it has an additional lumen here that can actually be connected directly to a suction catheter that's connected to wall suction. And what it'll do, this suction, as we turn on the suction, there's an opening here just at the top of the cuff that will actually go and suction out all of the secretion. So every 4 hours, for example, you can connect the suction. It will suction out any accumulation that there is above the cuff, and will go directly into our suction canisters. So these tubes may be found in some of the hospitals or in some clinical units. Now it's the same idea with a tracheostomy tube. A tracheostomy tube also has a balloon when patients are ventilated. So this balloon here that we would inflate, and it serves the same purpose as it would on an endotracheal tube. The other option is that you have a cuffless tracheostomy tube, and these are going to be for patients that are on any medical surgical floors or in rehab. They would have a cuffless tracheostomy tube, as they don't require mechanical ventilation. In the event that they would require mechanical ventilation in a critical care unit, we would have to switch the tracheostomy, and that would be done by one of the teams of physicians that would change this tube. With the tracheostomy, this one, for example, or similarly to this one, you have an inner cannula that you can remove in order to clean. This is an inner cannula that you would keep, so it's not a disposable inner cannula, but these inner cannulas, once they are in, are connected directly to the tubing from the ventilator as such. You can also find tracheostomy that has a disposable inner cannula. So this is a cannula that every time you clean the tracheostomy, you can dispose of this cannula and insert a brand new one. Now, when the endotracheal tube is inserted into the mouth, this is done by physicians, or it could be inserted by a respiratory therapist. So we will just partially insert it for the purpose of this demonstration. And then this would be taped around and around the face just to secure it in place. So once this is connected, the balloon would be inflated. We would remove this syringe, and this would be connected to our ventilator like this. One of the devices that we often use in critical care settings, however, is an inline suction. So this device here would actually connect a little bit differently, like this, to our patients. And what this will actually do is, if our patients require a lot of suctioning, if they had a pneumonia and had thick secretions that we often needed to remove, we can actually remove them using this device instead of continuously inserting a new suction catheter every time. So this here would be connected to our suction, our wall suction, and would remain like such on our patients. So the way that we suction, which is one of the roles of the nurses in critical care, to suction if ever for any reason there's too many secretions, this is how we would do it. So there's a button here where I could press down right now. If I were to turn it, this would be locked. So this should be locked most of the time, generally speaking, when you're just caring for your patients or they're just in bed, it should be locked. When you are ready to suction, however, we would go and unlock this button here. Before we suction our patients, we normally would give them, there's a button on the monitor that we are able to press 100% of oxygen. So it's a bolus of oxygen. So we call it pre-oxygenating our patients prior to suctioning them. The reason we do that, and we especially do that in pediatrics, is actually because as we're going to suction secretions out of the patient, it's essentially we're sucking out the air as well. So patients feel very breathless, evidently, when we suction them. So we do try to make it as quickly as possible, but ensuring that we remove the secretions that need to be removed. So once we're ready to suction, what we would do is is remove the safeguard here on the tube. We would give 100% bolus to our patients, and then we would be ready to suction them. We would obviously inform them that we're going to do such a maneuver. One of the ways to remain safe and ensure that the tube does not move too much or that no disconnections occur, I normally hold the tube just like this with my fingers. I hold the tubing here because there is a way to disconnect here, so we wouldn't want that to be disconnected. So I hold like this, and I'm able to, inside there's a catheter, I'm able to push through this catheter inside the lungs. As you may see here, there's a little black mark here, and that's just moving into the lungs. So this suction catheter is going in, and there are gratings on this suction catheter that we are able to see how deep we go. So once we go for our first suction, we have a general idea of how deep we must go, because as we push, we will feel the carina, so we won't be able to go any further. We always, once we feel the carina, pull back just a little bit to ensure that we're not going to suction the carina and injure the membrane. And then we start pressing on our button, which will be our suction. And as we press, we pull. It's a continuous press. We do not want to press on and off. We really want to go continuously. We want to ensure we're pulled all the way out so that we see this big black mark that was there. We want to make sure that we can see this so that we know that we're correctly out of the lungs and there's no suction catheter that's blocking any of the air going into our patient. So once we've done that suction, that's great. If we needed another one, we can go ahead after giving the patient a break. We can go and suction one more time. If we're done, we can just go here and lock our device to ensure that it doesn't accidentally get pushed down, and then we're actually just kind of sucking on the air that this ventilator is providing to our patients. If ever for any reason the secretions that are in this tube, I mean, they remain sterile in the sense that the system is sterile, but if we do want to clean out this tubing as it gets sometimes dry and crusty and very thick secretions, there is actually a way to connect a bit of a normal saline a little squirt bottle that we would actually connect right over here in this hole, and as we squeeze on the bottle, we would actually suction all that normal saline, so it'll go in here into our tubing and clean out our tubing. So you may see that happen as well. Now there is a way, if ever an inline is not doing, not removing all the secretions that we would want, there is a way to use a sterile suction catheter as we would for anyone that has a tracheostomy on a medical surgical unit. We would be able to open that package, that suction catheter package, but we would want to make sure that we have a pad to absorb, because as we disconnect this entire assembly, essentially, there's a lot of condensed air, like humidified air that's here, and there might be some fluid that can splash back. So we want to make sure that we have something to cover the patient. We want to make sure that we have a face shield and a mask to ensure that we don't get anything in our face or in our eyes. And so there would be a way to, after giving an oxygen bolus, disconnecting our patient from here and then fishing through our suction catheter to go and suction our patient's lungs and back out. Sometimes this allows us to do our circular motions that will really try to clean out our entire airway, but again, a continuous suction. We don't want that to be intermittent. In the event that we actually have suction a mucus plug, we would not want to release it every time that we do our intermittent suction. So this is called an inline suction, so you may see this in some settings, or as I said, it might not be there and you would have to use your own suction catheters in order to suction our patients. So this is a role of both the nurse and the respiratory therapist that would do this type of work. Now, if your patient were to have a tracheostomy instead of an endotracheal tube, there are smaller suction, inline suctions. As you can see here, the length is very different. Just because with the tracheostomy, the purpose of the tracheostomy is that it actually removes the dead space from the mouth all the way to where the tracheostomy is placed. So this is, dead space is a space in our body that is not used for gas exchange. And so therefore we don't have to go as deep because we've already kind of removed that distance. hence why it's much shorter. Another big role for nurses is actually mouth care. So this is something that you'll likely be doing a lot in some of these critical care settings, especially with intubated patients. Mouth care is required for the prevention of ventilator-associated pneumonia or ventilator-associated like adverse events, essentially. And so mouth care, you might have a device, just an actual simple toothbrush. Here, the specific thing about this toothbrush is that there's just a port here that we can actually block. So what ends up happening is that we can connect it to a suction catheter, and as we press on this hole, it will actually suction everything out. So as we go in the patient's mouth, putting whatever product that we need to put, usually chlorhexidine is what we use to clean our patients' mouths. As we go and brush their teeth, we are pressing on the suction to ensure that we don't drop any of that chlorhexidine or whatever mouthwash that we're putting. We ensure that it does not drop into their lungs and may cause ventilator-associated pneumonia. So this is an important role for the nurse, the mouth care, done every 4 hours in a ventilated patient. Another thing that may be of importance, just that we can demonstrate, is actually the use of a valve mask. So in any type of cardiac arrest, this is the type of device that you would be using to provide the breaths. But there is a chance, for whatever reason, that there's a malfunction with the ventilator, or there's actually maybe even a mucus plug, or anything that might be happening with your patient, that you might have to disconnect them from the ventilator and provide them with breaths through this device. Now, if they're not intubated, we would use the face mask. But if they were intubated, there is a way to connect this bag directly to the endotracheal tube. So this is a possibility, and then we would just provide the ventilator breaths this way. Now, obviously, this needs to be connected to oxygen, so do not forget to connect that. Turn your oxygen on when you're providing these breaths. So that's some of the responsibilities as a nurse when it comes to caring for these patients. Is mouth care, ensuring that there's that the airway is protected and safe, and also suctioning is a big responsibility. Also comes with that is communicating with your patients. Having an endotracheal tube, they cannot speak. Therefore, you need to find different strategies to be able to communicate with these patients. They often can't tell you they have secretions, so one way to actually know if they have secretions, sometimes you'll see it very clearly on the monitor, as a lot of the waveforms will be very wobbly and scribbly. Another way is through your assessment as you're auscultating the lungs. Sometimes just putting your hand on their chest, you will feel their chest vibrating, and you would actually know that they have secretions. Or the other option is as you just hold the tubing, you will actually feel them vibrating quite a bit. And so that's usually an indicator that there are secretions in the large airways that you would be able to easily go suction out with this inline suction. So that was invasive mechanical ventilation. Now, if you want to talk about non-invasive mechanical ventilation, one of the most common ones that you will see is actually this is a BiPAP or a CPAP mask. So like we might have CPAP at home, for sleep apnea, it's a little bit of the same idea, where you can have it's continuous positive airway pressure. So what it does is that it's a way to support our patients. A lot of times patients with COPD will find themselves with this type of ventilation before they get intubated, just because of the risks and the difficulties of extubating these patients. But this provides them with positive airway pressure to help push air into the lungs. If they have a lot of work breathing, it will decrease that work breathing. And it also ensures that on exhalation that they do not obstruct. And so that there's always a positive pressure, so usually a bilevel, so BiPAP, so bilevel inspiratory positive airway pressure. So it'll have a higher pressure on inspiration, lower pressure on expiration, but it's provided through this device here. You could also have, again, like I said, a CPAP where it's just one continuous pressure, usually not as high as the BiPAP pressures. And these could just help, mostly related to sleep apnea. So this BiPAP machine can be provided through the same ventilator that you would have invasive mechanical ventilation, but essentially the ventilator would connect here to a BiPAP mask, and this would be fitted on the patient's face. So this is one way of non-invasive mechanical ventilation. Another way is through this here. These are nasal prongs, and they actually provide, so these goes into the nose, they actually provide high flow oxygen therapy. So what we mean by that is as you use Venturi mask for just oxygen therapy, like any nasal prongs that you might use, this provides high flow, which means the flow of air of oxygenated air coming to the patients is very high. So these are really for oxygen deprived patients that need high levels of oxygen. And having such a high flow of oxygen coming into their lungs actually provides them a certain amount of pressure to ensure that the airway is nice and open, similarly to a CPAP in a way. So this goes into the patient and is connected to a device, to soft tubing that is humidified and is heated so as to ensure that the patients are comfortable. We have a tendency to put patients that require oxygen therapy that don't need to be intubated. We will give this to them instead of a Venturi mask, because Venturi mask, if they want to speak or if they want to eat, they are unable to do that, assuming that they cannot tolerate simply nasal prongs. So we will put this as more of a comfort measure. So this is usually really helpful for those patients that really are oxygen deprived for whatever reason. So this is another device that you might hear, so it's high flow oxygen therapy.